Welcome to Dr. Balga's podcast for the Curious Doc. Today is March 30th, 2026. This video is on two New England Journal of Medicine articles with accompanying editorials. The first is titled Left Atrial Appendage Closure or Anticoagulation with Atrial Fibrillation, published March 28th in the NEJM. Atrial fibrillation increases stroke risk. Anticoagulation reduces stroke but increases bleeding. So the investigators evaluated left atrial appendage closure versus anticoagulation in 3,000 patients, randomized 1499 to the device group and 1501 to the NOAC group. It was a prospective international randomized controlled trial with the acronym Champion AF. Mean age 71.7 years. 31.9% were women. CHADS2 VAS score was 3.5. Hasblad score was 1.3. Follow-up was for 3 years. The primary efficacy was cardiovascular death, stroke, systemic embolism. The non-inferiority margin was 4.8%. The primary safety endpoint was non-procedure related bleeding, and they're looking for superiority. They used Kaplan-Meier analysis and intention to treat. What did they find? The primary efficacy endpoint 5.7% in the LAA closure group and 4.8% in the NOAC group. P-value was 0.001 for non-inferiority. For bleeding, 10.9% in the appendage closure group versus 19.0% in the NOAC group. The hazard ratio 0.55, p-value 0.001 for superiority. Stroke risk was 3.6% in the appendage closure group versus 2.5% in the NOAC group. Cardiovascular death was similar, 2.7% in both groups. The net clinical benefit 15.1% in the left atrial appendage closure group versus 21.8% in the NOAC group. The limitations of the study: it was a single device, modest risk population, there was crossover, and the absolute non-inferiority margin was not achieved. Key takeaways: non-inferior efficacy, superior bleeding profile, the left atrial appendage exposure was an alternative to NOAC in selected patients. The editorial exposure: the key argument was left atrial appendage closure risk becoming overused despite borderline evidence. Core tension, stroke prevention versus bleeding trade-off. The evidence was in PROC 17, it was non-inferior to anticoagulation, while in closure AF failed non-inferiority, higher complication in older patients. The concerns, of course, were the periprocedural complications, 5.7%, major bleeding driven by procedural events. Numerical excess of cardiovascular death signals caution. The broader message: it parallels with renal denervation and PCI overuse. The technology, however, may outpace the evidence. The key clinical takeaway with left atrial appendage closure: its individual decision making is essential. Medical therapy remains standard, especially in older and frail patients. So the key clinical pearls with the left atrial appendage closure: lower bleeding advantage drives benefit. Stroke slightly numerically higher with the device is of concern. Procedure risk: pericardial effusion 0.7%, device thrombosis 4.8%. Shared decision making is essential. Long-term 5-year data is awaited. The next study we are going to discuss was published March 18, 2026 in the New England Journal of Medicine, titled Left Atrial Appendage Closure or Medical Therapy in Atrial Fibrillation. There was an accompanying editorial titled Left Atrial Appendage Closure, Another Overused Method in Cardiology. The objective was to compare left atrial appendage closure versus best medical therapy. The randomized controlled trial of 888 patients, median age 79 years, um, with high stroke and bleeding risk population, follow-up median 3 years, intervention percutaneous left atrial appendage closure versus physician-directed medical therapy. Statistics: the primary composite outcome was assessed for non-inferiority with an intention to treat analysis. What did they find? Left atrial appendage closure failed to demonstrate non-inferiority versus medical therapy. Periprocedural complications by 5.7%. Major bleeding higher in device group due to procedural events. Cardiovascular death 65 in the device group versus 51 in the medical group. Interpretation: no clear advantage of left atrial appendage closure in older high-risk patients. Limitations: the population was older and frail. Short follow-up versus prior trials. Procedural risk was significant. Key takeaways: medical therapy remains standard in elderly. Left atrial appendage closure may have selective role in younger patients. Careful patient selection is critical. Editorial perspective: this closure AF challenges enthusiasm for left atrial appendage closure. Quote message: technology may outpace the evidence. Prague 17 showed non-inferiority, closure AF did not. Clinical warning: procedural complications and bleeding offset benefits. Philosophy: avoid replacing proven therapy without clear advantage. Clinical pearls: stroke prevention must balance bleeding and procedural risk. Left atrial appendage closure is not benign. Procedural complications matter. Older patients derive less benefit. Medical therapy remains cornerstone. Again, individualized decision making is essential. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.